first, COVID-19 happened, and it was something that was a stressor and a challenge for everybody in the world. And in particular, it was very difficult for many of the sites and settings that provide direct services to members in the community. We had limitations in terms of face-to-face in-person interactions. We also had, more significant travel restrictions, and that resulted in, possibly less support to the staff members that we were supervising. And then also that translated to the supports that can be given directly to the women in the program. That might have something to do with why we also heard from many of the staff in the program that, this work was very challenging and was an added burden that, they weren't sure that they could take on. So, this is something that is important for us to keep in mind, that the acceptability of the program really requires additional supervision and implementation support at the organizational level as well as the provider level. So in the future, we would probably want to focus more on that, especially at the outset. The next set of challenges I want to talk about are related to the women that we serve and what we might want to do at the individual level. So, through the training as well as through the sessions themselves, financial stressors emerge as one of the top stressors that these women face, and the individual, therapy focus on problem solving is not enough. It's not adequate to support them to navigate some of the financial stressors. While the program was successful and was shown to improve depression outcomes, I think a more integrated approach where we're thinking about livelihood support, where we're thinking about socioeconomic supports is necessary for the program to address the full range of needs that these women have. And that relates to the next set of concerns that surfaced during our sessions, which is related to the social inequalities, the gender inequalities that women face in Uganda and in many places around the world, where the expected gender roles that they need to play really undermines their autonomy, authority, and ability to navigate their lives in many ways. And it also is a major source of stress. Related to that is gender-based violence and exposure to that, and the unfortunate normalization of that, even within their own families. So, that really impacts the social and emotional support they're going to get from their immediate network of supporters. And so I think, in the future, we want to pay more attention to that and integrate, a more focused attention on, how that might impact, their life, as well as having a much more trauma-informed care process and supports that involve not just the women, but their families as well as their partners. First, task-sharing depression care with non-mental health providers, such as midwives and peer mothers, is effective. It's effective for not only improving maternal mental health, but also helps women to better manage their parenting and care for their infant. This is why it's so important for us to integrate mental health and psychosocial supports into antenatal care. To do this, we need to integrate these interventions into already established programs to ensure sustainability and to consider ways to feasibly integrate new tasks such as screening and counseling into the workflows. As many of you are aware, the mental health of providers is critical for maintaining these programs. The risk of burnout is high, and this issue needs to be recognized and addressed in a more intentional and targeted way. It's particularly useful to support this in regular, structured, and supportive supervision and mentorship of staff. As they're integrating new roles and tasks into antenatal care, getting this kind of support can help prevent provider burnout. Lastly, to scale up mental health integration, we need to partner with a wide range of stakeholders, including government officials, local and religious leaders, and community health workers. This is an important strategy for supporting mental health integration, to include task sharing guidelines, for example, into local and national healthcare policy.